Good afternoon, everyone. My name is Nana Young, and I'm an Applied Data Ethics Fellow at USF's Center for Applied Data Ethics, also known as CADE. Trained as a bioethicist, I spend my time at CADE exploring my interests in the societal and ethical implications of disruptive innovation, and I brainstorm ways to leverage the power of that innovation toward the public good, whether that's through policy advocacy, research, or learning. I'm very excited to welcome you to today's panel discussion titled On the Front Line with the COVID-19 Vaccine. Today we welcome USF Professor Dr. Taryn Vian, USF's Director of the Master of Public Health Program. Through her research in over 40 countries, she has furthered efforts to control corruption, strengthen access to medicines, and improve community health initiatives. Dr. Vian has collaborated with the United Nations Development Program as part of the Anti-Corruption, Transparency, and Accountability Alliance. She's also served as an advisor to the World Bank and the Bill and Melinda Gates Foundation. Dr. Vian is a retired Peace Corps volunteer and earned her Ph.D. in Public Policy and Global Health from Boston University, as well as the Master of Science in Health Policy and Management from the Harvard School of Public Health. We're also very excited to welcome USF alum Fred Angulo. Since 2010, he has been part of the CDC Center for Global Health, serving as director of the Global Disease Detection Program, which conducts infectious disease capacity building efforts in more than 25 countries. Since 2018, Fred has worked for Pfizer as the lead Clinical Epidemiologic Centers of Excellence. Fred earned both his BS and MS degrees in biology from USF. He continued his education at UC Davis, where he earned his doctorate of veterinary medicine. He capped his education earning a doctorate of philosophy focused on epidemiology from UCLA. Today's discussion will be moderated by USF professor Dr. Christina Tzagarakis-Foster, who earned her BS in biology from USF. She then continued her education at UC Davis, where she earned her PhD in microbiology. We are very fortunate to have USF's Dr. Annette Regan, the co-director of the Community Health Practice Concentration, with over 14 years of experience leading epidemiologic research and public health practice. She will be online to answer your vaccine-related questions during the live event, so please post your questions to this broadcast on social media. Before we join our panelists, please do enjoy this incredible video showcasing USF's nursing students and partners who are currently on the front lines, leading the way and helping to put an end to this pandemic.
This semester has been very challenging, as you know, because of the pandemic. Our students were not given clinical facility to practice the sophomore one nursing clinicals. So we were conducting our clinicals through Zoom every single week until we heard that there is a partnership between University of San Francisco School of Nursing with Kaiser Permanente. We were all so delighted, and we work on our requisites to make sure we are safe for the patients and to the community and to the staff of Kaiser Permanente.
I truly love the values that USF's BSN program holds about the cura personalis. When the vaccinations were rolling out, students were able to line up and get vaccinations at St. Mary's and make appointments, which is awesome because I haven't heard any other school that were able to help students get their own vaccinations. Even when we were on campus, USF has made the Dawn's health check to make sure that everyone coming on campus is extremely healthy.
They actually had us on board and do a lot of COVID-19 videos so we can get educated on both the vaccine and how COVID works.
Finally, when Professor Andrade said that we were going to be at the Coret Health Center giving vaccinations and helping the community, I was over the moon.
In vaccination clinic, our student gained so much experience that they will not be able to do it on Zoom. Meeting patients, greeting them, having that compassionate and therapeutic communication with them, administering really the vaccination itself.
I was kind of nervous because I was like, oh my gosh, we learned about all this stuff through clinical, but I actually never have been able to give an actual vaccine. As people started coming in, and as like I did one, and then I did the second, and then the third, I got more into the rhythm of it.
This conversation was not there in Zoom classes. We were just learning, but being on field and having that interaction, learning to communicate with patients during our first sophomore is a great experience.
On our last day, there are balloons all over the clinic, and it says, "We love our nurses," like, "Thank you for our nurses." We are walking in the clinic and we are moved with this. And I still have chills in my spine. I'm getting teary and emotional. And how Sarita said, "Thank you very much, nursing students. We appreciate your participation and your, what you have done, your assistance in this endeavor."
It was honestly so heartfelt and so moving to be recognized so early in the start of our career.
I was like on the top of the world when we left the clinic, and it was a proud moment to be a part of her history, to be a part of that journey.
Nana, for that warm welcome. That was a very inspiring video. It is truly amazing to see our students, our faculty, and our staff contributing to the efforts to protect our community against COVID-19. I'm very honored today to welcome Dr. Fred Angulo and Dr. Taryn Vian. Thank you both for being here to be part of this discussion today. And welcome to our USF community and to all of those in the audience that are taking the time to listen to this very important conversation today. We have a lot of territory to cover, so I'm going to jump right in with the first question for you, Fred. You've had and continue to have a very productive and impactful career. As a USF alum, actually a double Dawn, as Nana mentioned, earning both your bachelor's and master's degrees at USF. How did your USF education prepare you for what was to come for your career?
Thank you, Christina, and thank you for the invitation to serve on this panel. I entered USF as a naive freshman and had little idea of what I would be doing in the future. And I left USF in 1983, well prepared with a solid foundation for a career in public health. And I just am so thankful that I had the time on the hilltop to build that foundation.
I share that same passion for USF as a fellow alum myself. So it's hard to imagine that just a little over a year ago, the first doses were administered in the USF or US vaccine trial. Fred, could you give us a brief history on the creation of the Pfizer vaccine from development to delivery, and maybe speak to the design and technology that went on behind the scenes?
I'd be happy to. I'll show my some slides. Are you seeing the slides?
I don't see them quite yet.
Okay, apologies. Very good. Do you see them now?
I do. Thank
Very
you.
good. So it has been a remarkable journey from developing the vaccine to its delivery. It started in March last year, and we were very fortunate at Pfizer that we had a long-term relationship with a biotechnology company in Germany, BioNTech, which has been a leader in developing the messenger RNA technology. And we were actually developing an influenza vaccine with them. And when the genetic code for the COVID-19 virus was available, we were able to, or BioNTech was able to rapidly develop the mRNA vaccine, and we began discussions and a partnership in earnest with them in early March 2000, a year ago. And rapidly, within 2 months, we had started with 20 candidate vaccines and tested them in the laboratory settings and chose the candidate to begin using in humans two months later in May, and then after a 2-month initial trial in humans showing that the vaccine was safe. Then we began the large 44,000 phase 3 clinical trial in July, just 2 months after. And this was then published in the New England Journal of Medicine, the results of the large phase 3 clinical trial, which was in 6 different countries around the world. And as I mentioned, with 44,000 participants, half of whom received the vaccine, half of whom received the placebo. And this is a figure from the publication. And the red line shows the occurrences of COVID-19 cases that occurred in the placebo arm, so people that were unvaccinated. And the blue line shows numbers of COVID-19 cases occurring in the vaccine, the people that received the vaccine. And you see the very few people that received the vaccine actually became ill, demonstrating that the vaccine was working much better than we anticipated it would. FDA set a threshold of 50% efficacious, and we were hoping to have a 70% efficacious vaccine, and it turned out to be 95% efficacious in this phase 3 clinical trial. And through that, we were able to submit the package to FDA in November. It's actually on November 8th that we submitted the package to FDA, and we received our first approval actually in the United Kingdom in mid-December, and then received the FDA approval from their advisory board in mid-December, and finally had the first FDA approval on December 20th, and began vaccinations in the United States and in Europe. So how well is the vaccine working? Well, first, here's just showing each line represents different countries. I've just highlighted a couple of the countries. The country that has the highest vaccine coverage in the world is actually the Seychelles, but Israel is shown there with approaching 60% of all people in Israel, which is quite remarkable because 29% of the population in Israel is children, which aren't eligible to be vaccinated. So a very high proportion in Israel have been vaccinated. And we published this paper earlier this month, which shows how well the vaccine is working in Israel. And this shows the epi curve, which is the number of cases that are occurring each day over time. And you see how when the campaign launched in December, nationwide vaccination campaign in Israel, it was at the beginning of a large upsurge of cases. And there was a nationwide lockdown that would occurred in late December and continued. But then through the red box, there is the observational period for the study that I just showed. And even though the country began to open back up because the number of cases were declining, that was a consequence of the rapid uptake of the vaccine. And this is the last slide that I'll show, but it's just showing that as we track the progress and how well the vaccine is working, the top line shows the incidence, the rates of hospitalizations that are occurring in Israel each week. And the top line is unvaccinated people, and the bottom line is vaccinated people. And it just paints a picture of what the protection is that there are still hospitalized cases and serious cases of COVID-19 in Israel, but they're largely only occurring amongst unvaccinated people. The vaccinated people have not having any illness, and the country is completely reopened. So that answers the question of how well the vaccine is working. So I'll turn it back over to you, Christine.
Yeah, that rate is extraordinary. I remember when the data came out, and it just truly remarkable, and still stuns me, all this time later. Taryn, the next question for you. The world has eradicated only one human virus before. That was smallpox, and it was declared eradicated in 1980. Do you think SARS-CoV-2 can ever be eradicated?
Well, thank you, Christina. When we talk about eradication, what we're really talking about is the permanent reduction to zero of the incidence of the infection caused by the specific agent, and that means globally. something that's a step before that would be elimination of a disease. And that is when it's we have reduction to zero of the incidence of the specified disease in a particular population. So the journal Nature asked the question about can coronavirus be eradicated to about 100 scientists, including immunologists, virologists, and infectious disease researchers who were working with coronavirus. And 90% thought it could not be eradicated. They thought that coronavirus was going to become endemic, which means that it would continue to circulate in pockets in the global population. We have tried to eradicate other diseases besides smallpox. We've had eradication efforts for malaria, for yaws, for yellow fever, and most specifically now for polio, the paralytic polio, and also for guinea worm. And I think that it's very difficult to eradicate a disease. In part, some of the stars aligned really for smallpox for a number of reasons. One was that it was easy to identify the people who were infected in a timely way. And we don't quite have that with coronavirus because we have these asymptomatic cases, and we also, the symptoms do resemble other respiratory illnesses. For smallpox, we also did not have an animal reservoir, and we didn't have a natural environment reservoir. And for coronavirus, we do have this transmission from jumping from animals to people, and possibly the reverse. So I think that what we should concentrate on is the vaccination effort to control the spread of coronavirus rather than eradication.
Absolutely. Fred, I didn't know, did you want to add anything to that?
I think we're looking at a future where coronavirus will be a seasonal disease. We hope to get through the pandemic phase and get to that future phase of a seasonal disease that we hope can be controlled well with immunization.
Absolutely. So the next question for you, Fred. Most emerging infectious diseases and almost all recent pandemics originate in wildlife. And there's evidence that habitat loss due to climate change is bringing animals that can transmit some of these diseases in close contact with humans more frequently. Is there a way that we can get ahead of this dangerous trend?
Well, it's a difficult question because there's so many factors that go into the emergence and spread of a disease and a new disease. But we certainly can do, I would argue, a better job of detecting the emergence of new viruses and new diseases and responding to them when they are detected and controlling them, which we did not do well with this pandemic, of course. So a key for the future is more rapid detection, more rapid response, and more rapid control. And the recognition that we live in a global community, that therefore the weakest link in our global community, we're only as safe as everybody is. So we must build the capacity for countries around the world to rapidly detect, rapidly respond, and rapidly control all infectious diseases in order for us to be safe.
Absolutely. I think you bring up a really important point in that community of scientists really working together to help us to get there if we're faced with something like this again in the future. I just want to send a quick reminder out to our viewers that if you have any questions for Professor Annette Reagan, our infectious disease epidemiologist here at USF, please put your questions in the chat room and we'll try to get to them as promptly as possible. It was very exciting for those that watched the news this morning. A major milestone was announced that half of the states in the US have reached 50% or greater of US adults now being fully vaccinated against COVID-19, which is remarkable. We have had over 286 million doses administered. And with all of this truly, truly impressive news, there have been a very, very small, essentially minuscule number of people that have experienced some side effects. Taryn, what do you think? Should people trust the vaccine?
Short answer, yes, definitely trust the vaccine. But the longer answer is these vaccines have gone through extensive clinical trials with, as Fred described for the Pfizer vaccine, with thousands, tens of thousands of people involved. The side effects have been mostly mild. And it's also important to remember that we don't stop monitoring for side effects after a vaccine is approved by the FDA. We have continuous surveillance. Companies are doing phase 4 trials. And I think the fact that we detected the side effects in the Johnson & Johnson vaccine, that small number of side effects so quickly, shows that our systems in this sense are working. In the case of the Janssen Biotech Johnson & Johnson vaccine, the government did recommend pausing the use of the vaccine after that number of thrombolytic events were reported. And the data on the side effects and other information about the vaccine was re-reviewed by panels of the FDA and the European Medicine Authority as well. And what they found was that as of April, there had been 15 cases of what they call TTS, that's thrombocytopenia syndrome, in almost 8 million doses administered. All were women 18 to 54, and it is a condition, TTS, that is potentially life-threatening. However, it's extremely rare. So weighing the cost against the very large net public health benefits of preventing COVID, serious illnesses and deaths, a decision was made to resume that vaccine's use. And I think also information is now provided to women, and they've made an effort to have that in multiple languages and culturally appropriate communication to women, so they know there are alternate vaccines available to them for which there are not currently any reports of the rare blood clots. But I think it's very important to have options for vaccines, to have a one-dose option. Having the additional Johnson & Johnson vaccine certainly allows us to go faster in our vaccination campaign, but it's also especially helpful for reaching itinerant populations and people who are insecurely housed, and people like my brother-in-law who are afraid of needles.
Which is not trivial. It's certainly a population that needs to be addressed. Fred, anything, I want to make sure if there wasn't anything to add to that.
I think, as always, there's benefits and there are risks, and we should always be aware of the risks. But in this instance, the disease is so devastating, not just for you, but for your families and for the neighborhoods, that the risk-benefit ratio in almost all instances is just the prevention hugely outweighs the risk. But there is a risk that needs to be managed, and it is being closely monitored.
Absolutely. I mean, so many eyes are on this, and making that information very public, and which I actually think is a beneficial thing. There is always going to be some risk associated with this, as you both mentioned. And so it's important for the public to understand that and put it in context. When you hear these numbers and the percent vaccination rate we're getting to, it's truly extraordinary. Okay, so something that actually has been on my mind and has been the topic of a lot of conversations and in the news a lot lately is that of vaccine passports. So certainly as more people gain access to vaccines and become fully vaccinated, Taryn, do you foresee a vaccine passport becoming the norm in the US, maybe either for work or for events or for travel? Where are we on vaccine passports?
So I think this is a tricky situation. About 400 campuses have now put in place vaccine mandates ineffective in the fall for students and staff. And I should say 401 because USF just announced that this morning. And some healthcare organizations, even right now, mandate that staff should be vaccinated with the flu vaccine. So there is a tradition there. But most large employers are not yet willing to impose a vaccine mandate. They're trying to reach a balance between safety and accommodating staff who might be hesitant to get the vaccine or still face access barriers, because we still do have access barriers. Another issue is that the COVID-19 vaccine is still under emergency use authorization, although companies have applied for full approval. While many experts believe that it is legal for employers now, especially high-risk workplaces like factories and healthcare clinics, to require the vaccine, if they can do it in a non-discriminatory manner, the employers might still want to wait until the vaccine has full approval. Also, the state laws vary. We've seen that in Florida, they passed a law that prohibits businesses from requiring the vaccine in exchange for services. Globally, some countries are considering vaccine passes, and Israel, we heard about in Fred's presentation, has the Green Pass, which was implemented starting in February. In the US, we don't really have a culture of that kind of thing. We have a much more emphasis on privacy rights, and some people have raised the danger of databases that could be hacked or impacted by fraud. But it could be something that's instituted for travel, especially similar to the yellow fever vaccine card that I had to keep in my early years of doing a lot of travel in sub-Saharan Africa. I think a less divisive approach is going to be to not mandate vaccine, but create incentives for getting vaccinated. For example, VIP sections for those who are fully vaccinated at sporting venues, in gyms, in restaurants, where people feel they can get a special benefit from being vaccinated. They might have that incentive to go do it.
Absolutely.
I like the incentive of you get a free lottery ticket if you. Some states are providing lottery tickets to those.
Yes.
Who get
Yeah, I heard that.
People are getting very creative. It shouldn't surprise me, but it's always a little entertaining to see what's being offered to encourage either people to get vaccinated or some rewards for being vaccinated. It'll continue to be interesting, I'm sure. Fred, on to the next question. So earlier this spring, we were very, very fortunate to have you present to our biology students and our biotechnology students as part of one of our seminar courses. And during your presentation, and you also touched on it very briefly in your slides, you discussed the National Immunization Program in Israel, which I found incredibly fascinating. Maybe taking that and expanding it, how important is it that the whole world be vaccinated against COVID-19?
Well, let me provide a couple perspectives. First, it's essential that everybody get vaccinated, a high proportion of the population. I hope everybody that chooses will get vaccinated, have access to the vaccine, and I hope everybody will choose. But there are real issues on access, and much more has to be done to make the vaccine available to all people that would like to receive it. And we as a global public health community, we haven't done a very good job. The wealthy countries are achieving high vaccine uptake, and the poorer countries are not. So we need to improve that. And it gets back to my other answer to a previous question: is we're only as safe as in terms of preventing transmission of this virus, we're only going to be as safe as the vaccine level that occurs in all the countries in the world. So to be a safe global community, it behooves us to assist countries to achieve vaccine uptake. And there are initiatives in this regard, and they are gaining momentum, but we have a long way to go. And it's just going to, is taking time and will take time. But I do hope that we achieve vaccine coverage worldwide that is needed.
From the Israel study, what do you think, what were some of the successes to achieve such a high vaccination rate?
Well, the Green Pass, as was mentioned, it really incentivizes people to, and there also is a mandate in terms of, in Israel, the mandates to control the vaccine. If you're exposed to a person that it turns out to be PCR positive, infected, you have a mandatory quarantine for 14 days. You cannot leave your house for 14 days unless you're vaccinated. And if you're vaccinated, your quarantine you're free to leave your house. So there's a huge incentive to give you more freedom. And then many bars, restaurants, etc., allow people to enter the indoor spaces by just showing on your smartphone that you have the Green Pass, that you've been vaccinated. So there's an incentive to get vaccinated because you gain access to, as a matter of fact, there was just a soccer game, a football game earlier this month that had 15,000 spectators in the stadium, but the spectators all had Green Passes. You could enter and watch your sporting event if you had the Green Pass on your phone. And in fact, they had 15,000 people in the stands. So they've really done a great job of incentivizing getting the vaccine. Even amongst hard to convince communities, the ultra-Orthodox Jewish community was very reluctant to take the vaccine, as they have been with other vaccines. But these incentives have helped, I won't say convince, but help motivate them to in fact take the vaccine. And then the evidence of how much, how it's preventing illness has also motivated a lot of people, that the only people they're seeing in hospitals anymore are unvaccinated people.
Yeah, I mean, absolutely compelling to see that, right? Wonderful, thank you. So question for you, Taryn, what are the ways that we can increase the vaccine reach into underserved communities and those communities that are disproportionately affected by COVID-19, kind of this approach of the last mile delivery, so to speak?
Yeah, really good point. We do know that in the US, our vaccine coverage has been lower in highly vulnerable communities, high proportion of people of color, and also high proportion of people facing economic and social marginalization. And I would add there low educational attainment as well. Some statistics here in California, a study indicated that 32% of Hispanic residents had received at least one dose of the vaccine at the same time as 51% of white residents had. So we see these racial and ethnic disparities. And then another study from University of Southern California showed that 76% of adults with a bachelor degree had been vaccinated or intended to be vaccinated versus 53% of those without a degree. You know, it's almost a 50% difference in vaccination rates. So these are important disparities that we have to address. If we look at the states that have done better than other states, some of the things that we see that they've implemented include prioritizing people right from the start who were most disadvantaged or were people of color. And they did that not just, they went beyond age, because we know that these populations will have higher probability of being infected with COVID and of dying from COVID. So you're prioritizing based on that, not based on just on age. A second technique was actively monitoring and dealing with barriers to access. And this is a micro kind of thing that you have to do, and it requires a lot of attention, but you really need to look at each subpopulation, each community separately and say, this is the barrier here. This is how I'm going to address that. A third thing was giving free transportation to vaccination sites. Simple, but some states didn't do it, other states did. And fourth is collaborating with partners in these communities, including tribal health organizations and like the Indian Health Service. And those partnerships need to be developed and nurtured before we have a pandemic. I mean, you want to use these partnerships. It's not the time to start building trust after you already are in a pandemic. And so some states had been better about facilitating partnerships all along. I think we do need local solutions that are tailored, local vaccine administration and outreach to overcome those barriers. One last thing I'll say in relation to what Fred was saying about the global issues around vaccine access. 0.3% of vaccines administered around the world have gone to people in low-income countries, 0.3%. And there are 44 countries that have less than 2% of people who've gotten even one dose of a vaccine. And that represents regions all over the world, but it represents low-income countries. And the WHO Director General has said, and I'm going to quote, "The world is on the brink of a catastrophic moral failure, and the price of the failure will be paid with lives and livelihoods in the world's poorest countries." So I think it especially resonates with people who have, the USF mission and the Jesuit commitment to social justice to really think about the rest of the world. Thanks.
Yeah, absolutely. Those numbers are profound, and I appreciate you bringing that up, Taryn. And I do think it speaks to who we are at USF and our commitment to social justice. This is going to be in our world for quite some time, and there's lessons learned of how we can do a much better job for sure. So thank you for that. So Taryn, also for you, from a public health perspective, again, this is a question I've thought a lot about myself. How do we convince people to get the vaccine? I know we've chatted about it a little bit already, but maybe we can dive in a little bit deeper. What approaches work?
It's a great question, and a lot of people are working on this right now. Vaccine hesitancy, or some people like to refer to it as the inverse, vaccine confidence. It's important to remember it exists on a spectrum. It's not just you're either trusting it or not, but there's some people have some doubts. And so we really want to look deeper into that. We have to consider the reasons why they're hesitant and have a multi-pronged strategy for addressing those reasons. And my husband is working on this right now with VA, with veterans, looking more particularly at the reasons why people are hesitant. One group is the hardcore anti-vaccine people. And one study I read showed that they're actually pretty small, but they have a loud voice and they have a lot of followers online, millions of followers. But we shouldn't assume that all those followers are hardcore anti-vaccine people. So we should keep trying to promote some messages for them. A second group is people who have safety concerns. It was a vaccine developed quickly, and so some of them need more messaging around the safety and more proof of that. There are people like young people who think I'm not really at risk of COVID. They think they're not susceptible, and they think it's not so bad even if I do get COVID, I won't be really sick. And so I think what we need is really a lot more focus right now on the communication and on that deep analysis, so we can appeal to people's values with our messaging. Okay, you don't like government telling you what to do, but you care about the people in your community, you care about your family, you care about the people who go to your church or your place of worship. This affects them. And I think about a situation I had when I was in Africa working in Zaire, now the Democratic Republic of Congo. We had a program for health insurance that we had put in place, community-based health insurance, and people had paid for premiums. And at the end of the year, we went to the village and we asked, what did you think of the program? And they said, well, I didn't get sick. Can I have my money back? And we're like, well, no, that's not how insurance works. But we said to them, you didn't get sick, but did somebody in the village get sick? Oh yeah, Mbola got sick. See, your premium paid for Mbola's hospitalization and for her to get better. See how that works? And that really, they understood that. They could appreciate that. So I think the message is about you're getting vaccinated, not for you, but for the people you love, could be in that way a powerful message. Let me stop there. I have a lot to say.
And hearing what you're saying, I feel that, then we all have a role to play in this conversation, that those of us that have been vaccinated, those of us that are in different realms, whether it's public health or in the sciences, to relay this information. I think it's going to take that level of granularity that we're reaching out, and it's not going to come from a politician or a president. It's going to come at that level. At least I feel like that might be my experience.
Yeah, that's true. In general, I think people are very supportive of the vaccine, most people, but we really should emphasize getting the vaccine out there, overcoming these different barriers, because the more people that we have vaccinated, it becomes more socially acceptable. The messaging really will help us get some of those hesitant people as well.
Absolutely. Fred, anything to add to that?
Excellent answer. And I'm encouraged that it's been great, the response in the 12 to 15-year-olds, that there's been, and why can't we take lessons from our adolescents? They can teach us a lot, and they, so I think we just need to continue to educate, as well stated, and strive to get to a number where we will break the transmission of this virus if we achieve a high enough coverage in the population.
Absolutely.
Yes.
Taryn, we've already talked about it a little bit, maybe to just dig in a little bit deeper. Obviously, there's a lot of questions surrounding the ethics and distribution. And how do we move forward? How do we build a system which is more equitable? We've made maybe some mistakes along the way. How do we move forward?
Well, starting from what were our principles that came out of our federal government, our government, to guide the distribution of vaccines, and I think they were sound. We had ethical principles of maximizing benefits, minimizing harm, promoting justice, and mitigating inequalities. And to implement those principles, we asked the states and the counties to prioritize healthcare workers and people living in long-term care facilities first. And obviously they're at higher risk. That was a really good decision. After that, we set priorities based on occupation, favoring essential workers, people in food and agriculture, education, healthcare. That's where the devil is in the details. It worked to an extent, but not all people working in these priority sectors or industries had to perform their work on site in close proximity to others. And so it did lead to some unfairness. You hear about, a director or CEO of a food company. They're technically, an agricultural worker, but that's not the kind of agricultural worker we were thinking about. And the same thing happened with Stanford Health's algorithm for distributing vaccines within an individual facility, where they tried to prioritize, and they ended up favoring some administrators over frontline workers because they didn't use the most up-to-date data about who was actually caring for patients. And I don't think it was intentional, but I think these things, we were trying to go fast, we create general rules, and it's a bit hard. Another incident where there was unfairness or ethical issues was how the vaccine sites handled the extra doses. So we know that a vial has multiple doses in it, and once you open a vial, you've got to use that because you can't save it for another day. And so what do we do with those extra vials? And this is where framing is important. And in our education in the MPH, we try and help students see always a frame of social justice and ethics. People used a frame that was more technical, more business, like, we're going to waste money, so we have to use these vaccines right away. Who do you know? And they just relied on their network. But if you have someone running a vaccine distribution, they're likely a privileged person. And so who's ever in their network is also privileged. So we had those extra doses in one hospital in California going to, they called up a private school where the head of the hospital was on the board with the head of the private school, and they gave the vaccinations there. When really what we need to do, if we're putting on our social justice hat, ahead of time and thinking about this, is to have a plan where we partner with an NGO and we make sure they can do transportation, and we let people know there's going to be doses probably available at the end of the day. Let's get them to really high-risk people. But these are hard calls to make. The general rules do make sense from a feasibility standpoint. And I do think that organizations that had pre-existing partnerships and participatory leadership did tend to do better in terms of setting up really ethical distribution rules from the start.
Yeah, absolutely. I can definitely recall that specific case that you mentioned, cases where we had success stories. I know, up in Northern California, when they were in a similar situation, I don't know if a freezer went down, but getting distribution out very quickly in this tiny little town. And so much to learn from this. You bring up really excellent points about accessibility and outreach, and really just the fairness of the distribution. And it's going to take, again, this continued effort to keep those relationships, to build that network and maintain it from here and beyond. Absolutely. I'm going to jump back to the virus itself, Fred, and come to you. I know we discussed this when you were presenting at our seminar class, and I find this topic really extraordinarily interesting, and that of variants and whether we can keep ahead of the virus. Is this attainable?
Well, it is not unexpected that the virus is mutating. It's mutating all the time, and it's not surprising that some of those mutations give an advantage to the virus and allow it to be more transmissible. And that's what we have seen in several instances with the emergence of a more transmissible variant. Not unexpected. What we want to have in place is a surveillance system that's robust enough to detect those emergence and dissemination of variants rapidly, and then be able to continually test our vaccines to see if it's working well against those variants. And you can do that in a laboratory setting by using the serum from vaccinated people, and see if this, in the laboratory setting, the serum from a vaccinated person works well against this new virus variant. Or you can observe it in the community and see how well the vaccine is working in a real world setting against new variants as they occur. And we have been doing both quite robustly in many countries around the world, trying to understand how well our vaccine is working. And other companies, of course, are doing this too. And many public health agencies are doing this. How well is the vaccine working against the variants? And it gets to an important point about the probable need for boosters, because what is apparent is the vaccine is working well, providing good protection against even variants, but the variants are, but slightly less effective against the variants. And so if you have a higher immune level in your body's more immune, then you can still be protected against the variants. And the way that you maintain a high level of immunity is to get, if it's a 2-dose vaccine, get 2 doses of the vaccine, and perhaps you're going to need another boost of the vaccine a year later, probably, that will make sure that you maintain a high level of immunity so that even a variant as it emerges will not overcome your immunity. So we anticipate and are developing, as others are doing, a booster vaccine, a vaccine that will have a next generation vaccine that will give us this boost to make sure we still remain protected. And that's not unexpected, and it is in fact occurs with other viruses. As you know, we get boosters for other vaccines. But so we do need to continually monitor for emergence of variants. Variants themselves are increasing the likelihood that we will need boosters. There is not yet a variant that has emerged that has escaped the vaccine, but we're continuing to monitor it very closely.
Yeah, excellent. Yes, we're gathering data in real time, and so this might be a difficult, if not answerable at all, question. At what point do you think we might know about boosters, and if it's a requirement, at what point? How many months out from your complete vaccination is that required?
All very hot topics under current discussion, and a little bit exhausting because we're still, as discussed in the beginning of our talk, we're trying to achieve high uptake. So there's many people still that need to get vaccinated. And now we're talking about, okay, let's revaccinate everybody. And that's another, will it be endless? I don't think so. I think if we can get a high enough level of protection, we can disrupt this transmission. We'll have enough herd immunity to disrupt transmission. Perhaps, though, it might be required to have an annual vaccine against this coronavirus. That is a possibility that we don't know yet. The first vaccines were given in December, so we don't even have 6 months of protection data yet from a vaccinated person. So we're learning each month.
Absolutely. Question for you, Taryn, since you interface with our students, what are the challenges you can see for the coming years for the labor pool, the talent pool that might help contribute to preventing something like this in the future?
Sure. Well, I think that we know that since the 2008 recession, the workforce for public health really has declined. I think by one estimate, it was by 20%. Especially, we didn't have epidemiologists in many county public health offices at the start of the pandemic. And so we started at a deficit already. The Department of Labor really expects a growth in jobs. And I think there have been some rumors of support from the federal government for expanding the public health workforce. And so those will be all kinds of different jobs are needed. And some of them are bachelor level, some are certainly for the more management positions, might be master's level in public health. There's an estimate from the de Beaumont Foundation that 22% of public health staff were planning to retire. This is in the government workforce, planning to retire by 2023. So, and that was even higher among the management ranks. So I think we have seen also an acceleration of that trend, and that's not a good thing. As many of you have probably heard, the public health officers really were targeted during the pandemic, experienced a lot of harassment, of vandalism, even death threats. It just boggles my mind. And through that, what they were trying to do is just implement public health measures. They were trying to do their job, but it limited people's freedom. And so they were subject to that. So I think a real challenge, there are real needs and real challenges. We have to really protect the public health workers. We have to get people into those jobs and get them trained up on the job. But also, I hope we'll remember that motivation to do these difficult jobs, and Fred is talking about, possibly a booster, and the amount of work people have done without any vacation is incredible, but it's not sustainable. And having all the resources you need to do your job is really motivating. And so we need to get those supply chains to be fully equipped, the hospitals to have the equipment and the supplies and the PPE. We need data systems so people know what's happening. And we need really good communication systems so that people can be satisfied doing their job and not be so frustrated and discouraged and harassed. So I think those are some of the challenges as we meet the needs.
Excellent. Thank you, Taryn. So we have just a few minutes left, and I have a couple of quick questions for both of you. So for you, Fred, maybe we can start us off. What are some important lessons that you've learned in the past year and a half?
Well, the lessons which we all have learned, perhaps the hard way, is how important prevention is. And by prevention, extension of that is public health. And the fact that our public health infrastructure in this country had degraded to such an extent that it had is a shame. And we hope that a lesson learned is we can build back up the public health capacity for this country and countries around the world so that we can rapidly detect and rapidly respond and rapidly control future pandemics.
Absolutely. Taryn, what about you?
Well, I would have said the same thing that Fred said. So thank you, Fred. I really think we need to bring also public health and healthcare closer together, and other sectors as well, to really have a One Health kind of perspective on this. And we're doing that here at USF with interprofessional education. That's what I like about being a public health program in a school of nursing. You can really try and marry those essential jobs together. I think we need a less partisan and more coordinated response at the federal and state and local level in our government, with strong federal government direction and support. And I'm thrilled that one of our faculty, Rich Callahan, who's also in the School of Management, is on a very high profile committee, task force that's looking at the lessons learned in terms of public administration and governance from this.
Wonderful, thank you. So final question for both of you. The value of science and the importance of public health as a career has been, obviously highlighted more than ever. What advice do each of you have for our current and future students that might be interested in this career path? I'll start with you, Taryn.
Well, sure. I would say the field of public health is diverse. As I mentioned, there are a lot of jobs out there. Bachelor degree, no degree, master's degree, and also you shouldn't think that you need a biology background in public health. There are positions where you could use that kind of background, but you don't have to have that kind of background. And if you're making a career, if someone's making a career change, lots of room for people who have a lot of management experience, but now are touched by this pandemic and really want to work in public health. I think it's a great field where you can make a transition. And here at USF, we have a social justice oriented MPH degree. So shameless promotion of our MPH program. Please get in touch. We want to help people achieve their goals.
Excellent. How about you, Fred? What advice?
Well, I can just say how much I've loved my career in public health, and every day there are new challenges, but it's very satisfying to be working in a field that you work on social justice all the time. You are dealing with health issues in the community, which by its very nature is a social justice question. And so it's a perfect marriage for what we learn in our Jesuit education, what we learned in our Jesuit education, and a way to make the world a better place is through public health. So we need young people and old people in public health. It's a great field. I hope more people will join it.
Wonderful. Exceptional advice from both of you. I want to thank you both, Dr. Taryn Vian, Dr. Fred Angulo. To conclude our conversation, I'm very honored to introduce Father Paul Fitzgerald, the president of USF.
Thank you, Professor Tzagarakis-Foster, for moderating this really fascinating and informative conversation. Thank you, Dr. Angulo, for being an exemplary USF alum, changing the world from here. And then Professor Vian, thank you very much for giving that really great insight into what's the special sauce of a USF education. And that's true for your program, but it's true for every one of our more than 100 degree programs. And thanks especially to Dr. Annette Reagan, who was behind the scenes in the Q&A answering questions from viewers. And in that introductory video, I loved seeing our nursing students, our BSN students. I see them every day heading down to the Corette Center to work in the Kaiser Permanente vaccination clinic. It's only possible because literally hundreds of our BSN students and another 75 non-BSN students who are doing the check-ins and the paperwork. It's pretty much a student-run clinic with, a team of experts. A lot of great takeaways for all of us from this, but especially Fred, the remarkably fast development of a highly effective vaccine in real time is remarkable. It is, science, cutting edge in today's, the most advanced, the most rapid. It's spectacular. So, at USF, we are asking people, we're going to require vaccination, unless people for a religious reason or for a philosophical reason or for a medical reason choose not to. But to those people who are choosing a religious reason, let me just say, thank God for science. God gave us minds. God gave us minds. God created a world that has all of these rules written into it. Science is a theological discipline of uncovering the rules that God wove into creation. And that's why in the Catholic tradition, we have the kind of natural law theory, and that science is a religious pursuit. Also undergirding this conversation was the importance that we have to think of ourselves as members of a single human race, that we have to get this virus controlled around the world. For selfish reasons, because the variants are going to continue to arise in populations that are unvaccinated, but much more deeply, and especially in a moment where racism and tribalism and things are on the rise, we have to go exactly in the opposite direction and see every human person as a member of our one family. So just thank you very much for this presentation where you led us through the natural science and the social science. And I just want to just thank you for sharing this time with us. For all of you who tuned in, please continue to return to these sorts of events, virtual and soon in person, and probably live streamed as well. We've learned that high flex, I think, is the future, where we'll be in person and online at the same time. We are coming to the last year of our comprehensive campaign, and we're doing quite well. So thank you for all those folks who have been supporting the university, supporting scholarships for our amazing undergraduate and graduate students, supporting the research of our faculty who are continuing to push back, the boundaries of what's not yet known, and also supporting the community outreach that USF is doing, whether it's through this Kaiser Permanente partnership or our outreach into the Western Addition, or that kind of outreach that we do as a good citizen of this city and of this world. So again, thank you all for tuning in. Keep your eyes out for other fascinating programs like this. A final thank you to Fred and Taryn for educating us.
Thank you for educating me.
Thank you.